Thrombectomy 6 to 24 hours after stroke without mismatch between deficit and infarct. Definition: mechanical thrombectomy applied up to 24 hours after surgery and stroke may be beneficial for patients and increase the chance of neurological recovery by more than 60%. This disease is the second cause of death, the first in women, the first cause of acquired disability in adults, and the second cause of dementia. Ischemic stroke is the most common type of stroke, since it accounts for 80% of cause and occurs as a result of the interruption of blood flow in a cerebral artery due to occlusion by a clot thrombus.
For patients with acute ischemic stroke, endovascular thrombectomy within 6 hours after the onset of symptoms can improve outcomes. Patients with a disproportionately high NIH stroke score, given the size of the ischemic area on perfusion imaging, so-called clinical infarct mismatch, are more likely to recover function after thrombectomy. The DAWN trial tested whether patients in whom brain imaging showed proximal anterior cerebral vessel occlusion and clinical infarct mismatch would benefit from thrombectomy 6 to 24 hours after the onset of an ischemic stroke. 206 patients were randomly assigned to receive thrombectomy or standard medical care. The patients were then assessed at 90 days after stroke. The primary outcome of post-stroke disability on the utility-weighted modified Rankin scale showed a mean score of 5.5 for the thrombectomy group versus 3.4 for the standard care group, a statistically significant difference. Functional independence was achieved in 49% of patients in the thrombectomy group versus 13% in the standard care group. Procedural complications occurred in 7% of patients in the thrombectomy group. The rate of other adverse events, such as symptomatic intracranial hemorrhage and death, was similar between groups. The trial was stopped at 31 months when a planned interim analysis showed the superiority of thrombectomy. The authors conclude that in patients with acute anterior circulation stroke with clinical infarct mismatch, thrombectomy performed within 6 to 24 hours significantly reduced disability and improved functional independence at 90 days, as compared with standard medical care. Full trial results are available at nejm.org.
Application in medicine. In this case, rapid restitution of cerebral blood flow is essential to minimize injury and reduce sequelae. In some cases, it is possible through the application of thrombolytic drugs that, administered intravenously, can achieve the dissolution of the clot if they are administered before 4.5 hours from the onset of symptoms, but when these drugs cannot be applied or if they are not effective because the thrombus is very large and occludes a large cerebral artery, it is possible to remove it using a device that captures the thrombus endovascularly. This procedure is what is called mechanical thrombectomy.
My name is Raul Nogueira. I'm an interventional neurologist at Grady Memorial Hospital and a professor of neurology, neurosurgery, and radiology at Emory University. Just had the pleasure of presenting the time analysis of the DAWN trial on behalf of my core investigators. And essentially what you demonstrate today is that we are adding now, with these late trials of thrombectomy, some complexity to the whole time effect of endovascular therapy and outcomes. First, it has become clear that it's now key to understand there are actually 3 different time metrics in endovascular therapy for stroke. The time that the patient was last seen well at baseline, the actual ictus time, and finally the time that the symptoms were first observed by a witness or family member. Moreover, it has also become clear that you have to understand there are different outcome metrics when it comes to function outcome. So you can have the dichotomized modified rank scale, the full independence at 90 days, the scale of 0 to 2. You can do the ordinal shift analysis, and as was done in the Dawn trial, you can look at the difference in the average utility weight MRS score, which seems to be the most patient-centric way of looking at the data. So we start the analysis of the Dawn trial with the expectations that, as in the early window trials that didn't use advanced imaging necessarily to correct for, let's say, the time effect, we would see a time dependence on outcomes, and that was exactly not the case. The results overall support the notion that this principle of clinical core mismatch resets the clock, and as long as you have a clinical core mismatch at any point in time, you seem to equally benefit from endovascular reperfusion. I think that's a very important concept that essentially highlights the theory that collateral flow will buy you time to reperfuse any individual patient. And then patients with favorable imaging profile and high clinical severity should be reperfused regardless of time from symptoms onset.
The World Health Organization estimates that in the next 25 years, the indices of stroke will increase by 27%, so that from that CEN study group of stroke disease, it is considered necessary and adequate recognition of the disease as a medical emergency. One of the keys to success in stroke care is the speed with which their initial symptoms are detected and the emergency system is contacted. Symptoms: abrupt alteration of the language, sudden loss of strength or sensitivity, abrupt vision and impairment, loss of coordination of balance and/or headache, very intense and different from usual headache. Pros: treatment of ischemic stroke that can increase more than 60%. The probability of neurological recovery can be beneficial up to 24 hours after the stroke. Reduce mortality and disability.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
Cons: the World Health Organization in the next 25 years estimates that the incidence of stroke will increase by 27% if the ictus is not detected within 24 hours. The patient may die. Issue of bleeding everywhere. Cerebrovascular disease is the second cause of death and ranks third as a global cause of disability. In Ecuador, this disorder is one of the first causes of death since 1975, one year in which it reached the ninth place, and 25 years later, in 1990, it was positioned as the first cause of death in the country. Conclusion: the thrombectomy after 24 hours is very beneficial for the health of the patient because it reduces mortality and gives the patient more chance of having a good improvement. In our country should be used because there are many strokes due to stress or high-fat food, so the field of neurological, nutritional, and cardiovascular medicine should be innovation with disease treatments to reduce the mortality rate.
Over the last year, we have seen significant changes on how we approach stroke care. Now we have quite a few studies that show that patients who have an acute ischemic stroke might benefit from interventional therapies out to 24 hours. Before, it was restricted to 6 hours. Now, this is the intervention where a proceduralist goes through the groin all the way up to the brain and removes a clot that's lodged there, causing a blood flow to be impaired to that area, so blood cannot get to that area of the brain. And that procedure now, we know that there's people that can sustain their brain without having irreversible injury out to 24 hours. Before, we thought that was impossible. So that has been a great change. As a result of these changes, what we have seen is that now more patients are being triaged to the Comprehensive Stroke Center, like the one we have here at Baptist Hospital of Miami, so to see if this patient will be a candidate for this therapy out to 24 hours. So this results in more stroke alerts happening, but also EMS and paramedics bring more patients to comprehensive stroke centers, which are the centers that are capable and have the technology and resources to deliver this therapy. Ultimately, though, stroke presents the same way in men and women. Usually, we teach this with a FAST, and it's an acronym. F goes for unilateral face weakness, so you can have a droopy face. A is for arm weakness, or it could be the leg as well. S is for speech changes. Either the speech is slurred, or there seems like there's some problem with language, the person cannot understand or speak appropriately. And then T is for time, because time is very important for the interventions that we can do to prevent damage from a stroke. Stroke is a largely preventable disease. About 80% of stroke is preventable. There are some things you cannot do much about. One of them is aging, for example, and some of them might be genes. But for the majority, the bulk, you can really prevent stroke. Now, stroke is a very common disorder. We know that 1 out of 6 people are going to get them throughout their life. Actually, 1 in 5 women are going to get them throughout their life. It's the second leading cause of death in the world, 5th in the United States, and it's a leading cause of disability. So things that you can do, for example, include decreasing your alcohol intake, making sure that you check your blood pressure and that you don't have hypertension, and if you do, that you do things to lower that, making sure you don't have diabetes, following a healthy diet, losing weight, doing exercise, lowering cholesterol if you have it high. And those sorts of things are going to lower your risk of having a stroke 10, 20, 30 years down the line.
Thanks. See you.